Alright guys, let's resume. So, this is a really easy concept for smart people like you guys. When you think about stable angina, think about the lumen of a vessel with an atheromatous plaque occluding some of the available lumen because it is developing in the intima of our coronary artery. So this is our coronary artery, travels in the epicardium. We're gradually narrowing the lumen because this plaque will continue to bulge and take up this space. Right now it's just occupying this space. Over time, the plaque will reorganize itself and become part of the vessel. This just means that the extracellular matrix deposited will have vessels grow into it, and it will become like the weak link of a vessel wall. Even if this plaque is stable, there's still stenosis, as you can see, this area and this area. And stenotic coronary arteries is bad for blood flow. So that means that whatever myocardium is downstream from this, it's going to be struggling to get enough blood flow. So for example, whenever there is an increased demand such as in exercise, this coronary artery cannot appropriately vasodilate to meet the increased metabolic demands of the myocardium. Remember, adenosine only helps for 30 minutes. So within 30 minutes we've used up all our vasodilatory capacity and helping us provide blood whatever is distal to this obstruction, this stenotic lesion. So eventually you end up with temporary swelling of myocytes because the sodium-potassium ATPase is unable to eliminate sodium within the cell. Now that's the fundamental basis behind stable angina. Let's continue and talk about variant angina or Prince-Metal. So Prince-Metal is the spasmodic-like vasoconstriction of the coronary arteries, and this causes transmural ischemia. Remember, coronary artery, the large part, runs in the epicardium, but then it sends little branches that perforate through the myocardium and the endocardium. And this is in the epicardium here. This is our myocardium, this is our endocardium. Remember that the endocardium receives oxygen and nutrients from the blood actually within the chamber. So the subendocardium is the last layer that is reached. It doesn't matter in this case because there's vasoconstriction of the main coronary artery that's traveling in the epicardium that gives off these branches. So there's complete deprivation of blood flow through all of these layers. It is transmural ischemia because it involves the epicardium, the myocardium, and the subendocardial layer. Remember, the endocardium is free because it gets its nutrients by diffusion from the blood that's in the chamber. Now, what are some important triggers of coronary artery vasospasm? Everyone's favorite test question is the cocaine one, right? It's a powerful vasoconstrictor. It's a sympathomimetic. It causes really, really high levels of vasoconstriction. It gets your blood pressure way up. This is why chronic users can also get necrosis of the nasal septum due to chronic hypoxia mediated by vasoconstriction of the tiny arteries in the nasal septum. Another potential trigger are triptans. Remember, we use triptans to treat migraines because migraines are hypersensitive vasodilated meningeal vessels, right? So triptans come in there. Binding of that serotonergic receptor causes vasoconstriction of the meningeal arteries so that they are less dilated and irritated. But if you get a triptans effect in the coronary artery, that's really bad because you're going to induce vasoconstriction and you do not want your coronary arteries to do that. Another trigger is that wacky tobacco. Tobacco is really bad for you. It's a rather obvious one because some of the toxins in the tobacco cause direct endothelial cell damage. These vessels have endothelial cells. You can impair their ability to produce nitric oxide, and remember, nitric oxide is for vasodilatation. If you have low levels of nitric oxide, you start vasoconstricting. Again, that's a terrible situation for a coronary artery. Prince-Metal angina is a transmural deprivation of myocardial oxygen supply because there's vasoconstriction of the coronary artery vessels that run in the epicardium. Alright, another flash quiz. What condition must be present for a fetus with detransposition of the great vessels to remain viable? The presence of a shunt to allow adequate mixing of pulmonary and systemic blood, i.e. a ventricular septal defect, an ASD, or a patent foramen ovale. You can also have a patent ductus arteriosus. The main point is that you have to remember that there's two different circuits. There's a right-sided circuit and a left-sided circuit. The right ventricle is pumping into the pulmonary vasculature? No, it's going directly into the aorta, while the left ventricle is pumping into the lungs. And you need some sort of way to mix this because these are abnormal connections. And you have to have some sort of abnormal connection for allowing these two types of blood to mix with each other. So again, we've seen this image before. It is something important to reinforce. These neonates are in big trouble without some sort of abnormal communication. Why? Remember, the right atrium is receiving blood from the systemic circulation that is deoxygenated. And the right ventricle is going to receive this blood and pump it into the aorta, into the systemic circulation. It never had a chance to become oxygenated by the pulmonary vasculature at all. The same thing occurs on the left. There's independent circuit. It goes from the lungs into the left ventricle and then right back into the lungs, right? So that's why we need something like a patent ductus or an ASD or VSD to allow some sort of mixing. Now what about unstable or crescendo? So let's think about our vessel again with the plaque. So we have our plaque, which is here. So we have a vessel, and recently this plaque decided to rupture. And this helps me remember what it means for unstable. So this plaque was unstable, and that's why it ruptured, right? So remember how all the prothrombotic contents inside of this plaque are just now going to be liberated into the vessel. We can get an immediate formation of a thrombus if there's rupture of this fibrotic cap that's holding all of the necrotic debris inside. It does not have to be completely occluding the lumen after rupture, but the acute onset of more severe stenosis due to triggering of the clotting cascade and a platelet plug formation can severely limit blood flow to the myocardium distal to this newly formed thrombus. So we went from this cap to all of a sudden forming a clot, and now we've occluded this much, and only this little segment is left. So it's crescendo because it'll get worse due to this unstable plaque rupturing. So again, this is termed unstable or crescendo angina because the acute decrease in coronary blood flow means that you can have pain while at rest. That is key, pain at rest. In addition to that thrombus forming, it can continue to get larger and further deprive the myocardium from oxygen. Let's discuss a very high-yield concept. So if you've done the pharmacology section, you have seen this diagram before in the discussion of adenosine. We placed a lot of emphasis on comparing the before and after flows across the atheromatous blocks in each of these left branches, here and here. So, for example, if we give adenosine dipyridamole or regadenoson, so let's all write these. These are all drugs that are able to increase adenosine receptor stimulation within the coronary arteries, and that causes an increase in the diameter and caliber of these vessels. As you can see, this is before any of these agents, and this is after. The problem is that we dilated this and dilated this, but this stenotic branch was already maximally dilated because it was struggling to properly perfuse the myocardium distal to it. So giving these agents sounds like a good idea because we aim to increase flow by increasing the diameter in order to increase perfusion past that atherosclerotic impedance to flow. But that is actually very wrong. This is the phenomenon of coronary steal syndrome, in which giving adenosine or any other of these purine-like derivatives that stimulate that adenosine receptor will actually lead to the shunting of blood away from that atherosclerotic branch, because you open the other coronary artery branches that were not previously dilated. So as you can see here, there's only two flow vectors, and then we dilated the vessel, and now we have much more flow here. We dilated this segment, and there's much more flow. It is shunting down this coronary artery branch away from this already maximally dilated atherosclerotic branch. Basically, it is stealing blood flow away from this stenotic branch. That is why it's called coronary, because we're in the coronary arteries, and it's stealing blood away from it. This can further exacerbate the oxygen deprivation of the myocardium that is distal to this obstruction, right? This blood flow is very important, and now we're shunting blood away from it in this situation here after we gave one of these medications. That is actually the basis of stress testing. They use regadenoson to stimulate adenosine receptors to shunt blood away from areas to see if they become ischemic in situations of stress. So that is why you can get angina from giving someone adenosine, dipyridamole, or regadenoson, because you're essentially depriving their myocardium of oxygen, and that is how they get chest pain. We change the hemodynamics of the coronary vessels, and in an atherosclerotic patient, it is a terrible situation because we can shunt blood away from areas that are already struggling to adequately perfuse past these stenotic elements here. Now, let's move on to an incredibly important subject. You have to know this. We will really go more in depth in the coming slides about myocardial infarction, but let's take this opportunity to introduce some key fundamentals about the pathophysiology. So the initial trigger is a rupture of an atheromatous plaque that exposes necrotic plaque contents such as subendothelial collagen and tissue factor. Remember, the activated fibroblasts within the plaque are always actively laying down all types of extracellular matrix. The subendothelial collagen causes platelet activation and aggregation. The tissue factor initiates the clotting cascade. Both of these are really bad situations because we get an acute roadblock built in to this highway that's our coronary artery vessel. This newly formed thrombus prevents distal perfusion of important real estate. And by important real estate, I mean the patient's myocardium. Now, what about sudden cardiac death? What does this term even mean? There doesn't have to be any acute massive heart attack for these patients to unfortunately pass away. Most of the time, there's already pre-existing diffuse myocardial abnormalities. When I say abnormalities, we're talking about, so this is our ventricle, and when I say abnormalities, I'm talking about zones of scar tissue here, zones of scar tissue here, zones of scar tissue here and here, because this person has suffered acute anginal events over time that has killed off some myocytes, but they've healed with scarring. So these areas of scar are left over. Remember, the heart is not capable of regenerating itself. It can only heal by scar formation. So, not regeneration, but repair with scar tissue. So obviously these areas of fibrotic tissue do not conduct like you would expect a normal myocardium to conduct. This is a really dangerous situation to have scarring of the heart because it sets you up for a big difference in conduction capacities in tissues that are directly adjacent to each other. So for example, here this tissue is conducting fine. It's like having the autobahn here. This is a really fast highway of conduction directly next to this school bus lane where this fibrosis slows down the conducting ability of the tissue. There's a huge gap here between the conductive velocity of these two segments, the scarred myocardium versus the normal. So there's a big difference in the speed at which the impulses are conducted through these tissues that are right next to each other. This is a problem because these tissues are supposed to be depolarizing and repolarizing in unison. Remember that word, syncytium? Yeah, that's a big deal. Patients with sudden cardiac death, eventually one area does not activate in synchrony with the other. So for example, this area of scar will just say, oh, I missed the depolarization train, couldn't get it together, I was still repolarizing, I'm slow, I'm sorry. So the problem here is that when this tissue is actually done repolarizing, this fibrotic area will finally depolarize. And now it's going to depolarize at the time that this one is not going to respond. This is a dangerous situation because what if this depolarization occurs right at the time when this is just finished repolarizing? You get an immediate depolarization of this area. And now you can form a loop where this depolarization just activated this, and they can swing back around and form this little tiny microcircuit of a loop depolarization. Because now these areas are able to depolarize within themselves and form a nice little loop instead of depolarizing all together like you would expect a syncytium to do. So essentially we just created a loop in which this little wavelet of depolarization that was essentially, it was delayed because it came from the slowly responding scarred tissue. It will just circle back on itself where it originated. So let's make sure we understand this concept and repeat it real quick. So let's visualize this again. We have our ventricle. We have this area of the heart that's scarred. It is late responding to the initial depolarization. So this normal area has depolarized and is beginning to repolarize, while this segment missed out on that train completely. As this area finally finishes that depolarization and is repolarized, finally this segment depolarizes, and then it sets off a wave of depolarization that travels into these normal myocytes. We have essentially created an opportunity for a little micro reentrant loop. So what is the trigger that sets off these events leading to sudden cardiac death? Well, we just need some sort of challenge to stress our myocytes just a little bit more. For example, like activating the sympathetic nervous system, like when we exercise. The increased myocardial oxygen demand further disrupts perfusion to these already slowly conducting scarred fibrotic areas. In my mind, I think about it as follows. So let's say you get beta adrenergic signaling to your myocytes. You're going to have to increase the velocity at which you depolarize and repolarize. It's going to keep going faster and faster. The opening of channels and activity of pumps gets very risky at faster heart rates if all the myocytes are not healthy and performing together. It just takes one group of slightly ischemic and fibrotic myocytes to lag and get behind the rest of the group to mess things up. This disruption of ion conduction is also the basis of how a channelopathy can lead to sudden cardiac death. What am I talking about? I'm talking about long QT syndrome. There are abnormalities in repolarization, just like you would see occurring in the patient with a diseased myocardium from fibrosis. They are slow to repolarize due to some abnormal repolarization from a mutated potassium channel. Remember, potassium channels are responsible for our phase 3 repolarization in this segment. So what happens when we have a patient that has fibrosis and they have these micro-reentrant wavelets propagating through the ventricles? Well, it leads to fibrillation, ventricular fibrillation, because we're in the ventricles. The ventricular myocytes are not contracting in a synchronized fashion. So again, we have our ventricle. There's a little wavelet of depolarization and repolarization here, and here, and here, and here. These areas are contracting at different times. The heart is essentially just quivering because it's fibrillating, right? There's no unified contraction, then you're not going to pump blood forward because there's no unified compression of that blood and projection out of the chamber. So not only are you not providing blood to the rest of the body because you can't pump it out, you're not going to adequately perfuse your coronary arteries either. Now you get even more ischemia, and you can potentially get a huge infarct in a huge segment of myocardium. Sure enough, this will happen and a huge portion of your heart will die. That means your brain will soon follow because there's no forward perfusion to it. So hypertrophic cardiomyopathy also slips into the category of sudden cardiac death. This is an image of a hypertrophic heart. As you can see here, the wall thickness is incredibly impressive, and the lumen of our chamber is tiny. Look at that. So this is what we call concentric hypertrophy, right? Because the sarcomeres are added in parallel like this, and it narrowed the lumen slowly over time. Just keep on narrowing it. These patients obviously have hypertrophy or thickening of the myocardium, except that it is due to mutations in sarcomere genes that produce contractile elements that do not effectively create enough force to maintain adequate cardiac output. That is why these patients have hypertrophy. They have to add more sarcomeres in parallel to get that force high enough so that they can have appropriate cardiac output. This is compensatory concentric hypertrophy from birth because these patients have genetic mutations of their sarcomeres. So in addition to this thick, non-compliant hypertrophied left ventricle that has impaired diastolic filling, you have an increased risk for sudden cardiac death because these sarcomeres aren't working well at all to begin with. So how much blood do you think you can push into this chamber in diastole? Not very much, right? So you have a very small increase in volume for the pressure you generate. This again is the concept of poor compliance with hypertrophic cardiomyopathy. In about 1/4 of these patients, we need to be particularly concerned about hypertrophy of the subaortic septum. Let's visualize that a little bit better with a diagram. So the subaortic septum is part of the ventricular outflow tract. In the situation of hypertrophic cardiomyopathy, 1/4 of the patients with hypertrophic cardiomyopathy will have a hypertrophic subaortic septum. So this segment here will be abnormally hypertrophied and thick. Even though the rest of the chamber wall is very thick, this segment will be particularly large, like so. As you can see here, if the septum gets super thick, a hypertrophied septum decreases the diameter of the outflow tract. This is our outflow tract. This eventually means that we are not getting adequate forward perfusion of the body and the coronary arteries. This is obviously a problem because the myocytes can be deprived of adequate blood flow. They can develop ionic abnormalities, and just like how we discussed in unstable angina, they can progress to ventricular fibrillation and then suffer instant cardiac death. This is a relatively simple slide to understand. Chronic ischemic heart disease is an accumulation of ischemic events over time. So ischemia once, you're probably going to have it more than once if you have a baseline problem such as coronary artery disease. So you have ischemia, you get fibrosis, and then this keeps on happening over and over again. One more time, one more time, one more time. It's like suffering a skin wound that obliterates the stem cells in the basal layer. Without stem cells, you have to fill the defect left behind from the necrotic tissue with deposition of collagen. Remember, the heart, the brain, these are not regenerative tissues. These are tissues that can only repair with deposition of scar or collagen. Now let's move on and get to the high-yield information related to the histopathology and diagnosis of myocardial infarctions.